Hello, is Giancarlo Di Renzo speaking, one of the organizers of the International Fetal Cardiology Webcourse. Today, the second part. I would like to just inform there is a slight modification because Professor Rizzo, one of the moderators, is not being able to reach his position. He will be later, so I give the word and the podium to the other co-chair, which is Professor Valentina Tsivisova, and I let her to introduce the course and all the today session. Thank you, Valentina.
Thank you, Professor Di Renzo, for kind introduction. And so let me first say that this course had been organized by Preis School in Firenze, directed by Professor Di Renzo, in cooperation with the Wayne State University Medical School, with Professor Roberto Romero, with Chemer Institute in Perugia. In the first day, last Monday, we had a lecture dealt with basic examination in ultrasound, with examination of the function of the heart, remodeling of the heart, due to EGR and other pregnancy-related combination. Today is the second part, and we will deal mainly with the fetal heart malformation, and we will explore the advantages given by application, which may facilitate recognition of the abnormalities. In particular, I referring to the so-called method FINE, Fetal Intelligent Navigation Echocardiography, developed by Professor Lamiot, Professor Roberto Romero, and Dr. Gustavo Abella. Today, we have distinguished expert in fetal cardiography in this methodology, which will show us the advantages and tricks of this method. Let me introduce one of the inventors, Dr. Gustavo Abella, who is from Ecuador, lives in New York, who will introduce the FINE method. Dr. Gustavo Abella is computer scientist, president of MÉCH company based in New York, expert in informatic application to ultrasound examination and machine. Please, Dr. Gustavo.
Thank you very much. It's a real pleasure to be here. And this is the second part of the presentation. And today we will focus more into the, let's say, to the real clinical advantages of this modality or how it could eventually help doctors doing the diagnostic job. So thank you very much. I don't know if you want me to start now.
Yes, start, please.
Okay, I will share my screen. Okay, 1 second. Okay. Very good. So the, sorry, that's the other presentation. Second, please. Can you see my screen?
No, for the moment, no.
So 1 second, please. Okay. Hoping that you can see this now. Okay.
Yes.
Sorry for that. We will continue describing this method, FINE, that is a fetal intelligent navigation echocardiography. And in this case, we would like to explore the potential of FINE aiding in the diagnosis of the congenital heart defects. So why this could be, what is the value of this? As we already discussed in the other presentation, the fetal heart is the most difficult organ to study, and we believe that FINE could be an aid, a help in this sense. So FINE is available as a commercial product. In this case, it was incorporated by Samsung Healthcare Company. The OEM implemented the FINE method and they changed the name to 5V Heart. It's a trademark describing the FINE method. It is implemented in several models and several machines, including the flagship, the HERA W10. There are actually thousands of 5V Heart units already deployed and installed worldwide, and we believe that it contributes in the CHD management. So, first of all, what FINE delivers? FINE delivers 9 standard planes. The planes that are available: 3-vessel and trachea view, 4-chamber view, 5-chamber view, left ventricular outflow tract, right ventricular outflow tract, the abdomen view, the ductal arch, the aortic arch, and the vena cava. So the cava view. So these planes, they have a role not in screening, because in screening you normally don't need the long arches that much, but of course they are very, very useful for diagnosis. The main benefit of FINE is that these 9 planes are reproducible and reliable, meaning that if you use FINE correctly, you have an accuracy of 98% in those planes, so you can rely on them. This was published by Professor Yo and Romero in several journals. So there are 2 phases where FINE could be used. One is the screening phase or the diagnostic phase. We believe that the main role is during the diagnostic phase, because for screening, few planes are needed. The different societies were enforcing the extended and the basic approach for scanning the fetal heart. But if you go to the diagnosis, like the AIUM, American Heart Association, other societies, they require an extensive list of planes. And that's the aim of FINE. So we believe that the diagnosis, the gold standard, is 2D. No software can replace 2D. But it is very good and very helpful if you get already your diagnosis or even your suspicion to use the method, the FINE method, just as a complement, just a confirmation of your findings. So this increases the level, the degree of confidence. So the clinical purpose is basically once you detect a suspicion in 2D, then you can acquire a volume, mark the points, and get the planes with 98% of accuracy. So it is a valuable complement of the previously diagnosis that was done in 2D. You can consider this like your own second opinion. It's like having an expert handy, also scanning and confirming what you have seen or not, or disagreeing with your claims. So we believe that this increases the confidence of the findings, which is very important. And in some cases, it may lead to a refining or redefinition of the diagnosis based on the additional information you may get. This paper was produced by Dr. Lamillo, Dr. Sukaya Luman, and Roberto Romero. And this was a very interesting research on diagnostic value of the method. So basically, this is publicly available. Basically, the summary goes like this. The results of the study, they imply that the sensitivity to CHD was 98%. But the specificity also was very good, 93%. So FINE completely matched the diagnosis made in 2D, 74% of the cases. There were minor discrepancies in 12% and major discrepancies in 14%. Based on this, we believe that these numbers are very interesting and very good because they can somehow confirm what the sonographer already got, what the expert got on the screen. So the value of this is not for beginners. It's not for people without experience. The value of this is actually for doctors that are doing, let's say, like more advanced evaluation of the fetal heart. So the conclusion in the paper is that sensitivity and specificity of the FIND method in fetus with normal and pathologic and hearts with CHD in the second and third trimesters, it has been reported, and because of the inherent 98% sensitivity of to CHD of the FIND, this method can be used prenatally to screen and to diagnose the CHD. Or better said, if you are already doing your 2D exam, that is the gold standard and the mandatory process, then you can add another layer of confidence by doing this FIND method. I would like to describe how this works because the thing is that the heart, if it's distorted morphologically, could be difficult to be dissected with 98% accuracy. So let me describe the invention. So the process is that the user has to enter 7 points, 7 biomarkers that are unique to that particular heart, unique to each fetus being studied. Based on this marking, an internal model, an internal geometrical model is being generated. Now, that model has certain lines where the planes are. So the lines indicate where to cut the volume. And finally, based on those, let's say, trigonometrical or geometrical planes, these slices are retrieved from the volume data set, from the ultrasound image. So I would like to, I propose an analogy to our method to what is known as facial recognition. You know, the ability to identify one specific person based on certain geometrical parameters. So in this case, 2 people will surely have different physical complexions, faces or fingerprints. We also believe that these 2 people may have different hearts, unique hearts, that they are different to each other. So it could be possible by having certain biomarkers to identify them. So in the picture number 1, there are some markers assigned to the anatomy, to the structures. Those markers are creating a geometric model, and this is what is stored in the files in order to do facial recognition. You don't store the actual image of the person. You store the geometric model. So it's a more concise and let's say easy to manage information. So in this case, you can see how a geometric model is constructed. So different people may have different set of points according to the characteristics. So the thing is that the points are intended to adapt the slicing to a particular given heart, being normal or abnormal. So this is not like doing parallel, parallel slicing, tomographic slices of the heart that are fixed in their position. This is adaptative. So FIND geometric model has predefined where the standard planes to be cut should be. So even if the heart has morphological alterations, its geometrical model will preserve the correct position of the desired planes. So let me give this example. This is a globe that has an equator line, and the equator line could be the plane that we want. Okay, so we want to get the equator line. So the way to do this is to create a geometric model that, despite the globe's inflates, deflates, or deforms, still the geometric model can cope with these changes and deliver the slicing, the dissecting plane to get the equator line under all circumstances. So in this case, the equator line is here, and in this case, the equator line is there. But as long as the geometric model knows where the equator line is, it can obtain it despite the shape of the globe. That's the uniqueness of the method. So I would like to do some demonstration on how the system works. So in this case, I'm going to use a simulator. This is the Opus simulator. So this is me with my probe. So what to scan? So in 2D, when you scan, you can get the different planes, right? And there are a standard sequential segmental approach to do this evaluation. So we go first to the stomach, we define which place is left, we go to the heart, to the 4-chamber view, right? We try to obtain a better image. Then we go higher, we see that there is something in the septum. Then we go to the 3-vessel view, and now we can see that there is very little pulmonary artery. So a thick aorta and no pulmonary, or very little pulmonary. So the superior vena cava and the trachea is there, but this is already a big suspicion. So in order to get the name of the diagnosis, we need to see the tracts, right? So for example, we need to get LVOT, we see the overriding aorta. I mean, I'm manually scanning. Depending on how good I scan, I can get these planes. But depending on how the baby relies, it could be problematic. For example, if the patient is like lateral.
Final activity. The fetus is lateral.
So
Evaluate the heart once more.
So
press the space bar when you finish.
So if the fetus is lateral, then maybe some planes could be challenging to obtain. For example, the tracts, I don't know what to do with my hand. So this requires a lot of expertise to adapt yourself to the presentation of the baby. And this is probably part of
Next activity, vertex presentation. Perform a segmental sequential evaluation of the fetal heart. When you finish, press the space bar. Okay,
so probably this is an easy position because the spine is down. So then we can get more easy the different views. Like this is a better LVOT. Okay, now we know 2D is the gold standard, but we want to use the fine method. So how can we do this? So we go to the 4-chamber view, any 4-chamber view. It doesn't have to be in a specific location, although this is the best view because of lack of shadowing, but it could be like this, doesn't matter, or like that, doesn't matter, the system will manage. So let's do this. Okay, so I want to acquire a stick. I get the 4-chamber view, right? And now I want a stick. So I press the 5D hard button, and then I am getting a virtual stick. The simulator is nice in that sense because I learned how to get different kind of sticks. Now I'm in the fine environment. So I need to mark these 7 biomarkers that are actually very kind of easy because they are predictive. The system has intelligence and will help me. So I start with the aorta at the stomach. I need to confirm that this is the stomach. I can see the stomach, so I mark the aorta. Now it jumps automatically to the 4-chamber view. But please look that the 4-chamber view is frozen at the protosystole phase. Automatically, the system is sensitive to the cardiac phase. It's like having a virtual EKG inside the system. So now here I'm marking the aorta at 4-chamber view. Now, the system is asking me for requesting the crux. So I mark the crux. Now I align the line with the septum. And now I have a problem here because I need to mark the pulmonary valve. But where's the pulmonary? It's very difficult to get it. I think that the pulmonary is going to be the white valve that moves down. That is this one. So I will mark this one. And now the system is asking me for the superior vena cava again to know which one is the one that moves the less. That is, of course, is this one. And to conclude, it jumps to a more, let's say, cephalad position in order to get the transverse aortic arch. So now I will come here to mark it here. So this is a process. I'm describing the process. It's taking time because I'm talking, but shouldn't be too long. Based on this thing, I have these planes. So I can put the labels. So if I put the labels, I can see here that you can see that the pulmonary has an issue. So this is a positive for a problem, right? Now I will go to the other views. Now this is the 4-chamber view. Okay, so we have some suspicion here, but nothing else. Now this looks kind of normal. That is a problem of 4-chamber view in tetralogy, right? Now this is 5-chamber view. In 5-chamber view, you could see a little bit of a VSD, but in LVOT, you see the overriding aorta very clearly. Now, next one is going to be the right outflow tract, where you can see many things here. You can see that the ductus is the ductus arteriosus is very tiny. The pulmonary artery is not. So there is a little bit of passage of blood through the pulmonary valve, but not that many. And the annulus is also having some problem. Now, stomach is on its side. The ductal arch, of course, is not clear, and the aorta also is clear, having a lot of, let's say, it's thick because it's receiving blood from both ventricles, right? And then the caval view looks okay. So what is the diagnosis? Of course, it's a tetralogy. Conclusion: the fine method, it's already describing what we already saw. It's describing what we already saw in 2D. But it's a very good and very confident piece of information to complement my findings. So I think that this explanation, I hope this cover the presentation of today, and we are very, very pleased with the adoption of the method, and we believe that this is an aid, a tool, improving the detection rate and the specificity. Thank you very much.
Thank you, Gustavo, for your practical presentation, and please remain online for discussion. Now I want to invite the second speaker, Alexander Weichert. He's consultant obstetrician and gynecologist, maternal and fetal medicine subspecialist, University of Berlin.
Yeah, thank you so much for the invitation and giving me the opportunity to speak to you today about right heart anomalies. I will just quickly start the screen sharing. and start my presentation. Perfect, here it is. So today's topic is the diagnosis of right heart anomalies using the fetal intelligent navigation echocardiography that Gustavo showed to us. So let's talk first about the right heart. So when talking about the right heart or the right ventricle, we have to know that the right ventricle has been neglected for many years and even referred to as the so-called forgotten ventricle. And the right heart ventricle has emerged as the dominant ventricle in utero. So it's more important in the uterus because Doppler studies have shown that the stroke volume of the right ventricle in the fetus is 1/3 higher than the stroke volume of the left ventricle. What else? There is compelling evidence that right ventricular dysfunction contributes most to perinatal mortality, even in the presence of left-sided lesions such as the hypoplastic left heart syndrome. And studies have consistently demonstrated the central role of the right ventricular dysfunction in the prognosis as well as the outcome of a variety of acquired and congenital heart diseases. When looking at the fetal heart, any significant impairment of the flow that enters into the right heart results in an increase in the blood volume passing through the foramen ovale to reach the left-sided cavities. Let's talk now about right heart anomalies. Here we have the heart. And when talking about the right heart, we basically focus on two structures. One is the tricuspid valve, connecting the right atrium with the right ventricle, and the pulmonary valve, you see it up here, and the right ventricular outflow tract, like the mean pulmonary artery, as well as the ductus arteriosus. This is a paper published by Hoffman in 2002, and he evaluated the incidence of congenital heart defects, and the overall incidence of CHD was approximately 9,000 per 1 million live births. When we look at these different types of cardiac defects and compare them between the right and left side, we see that the majority of heart defects is from the right heart. Let's quickly talk about screening of congenital heart defects. Gustavo already told us a little bit about the different planes that need to be evaluated. But when going through the guidelines from different international societies, here we have the workflow published by the ISWOC, and it consists basically of 5 parallel planes. So the first plane is evaluation of the fetus to evaluate where's the left side of the fetus, where's the right side, where is the liver, where's the stomach. Then we go a little bit higher. Here we evaluate for chamber view, we have the right ventricle with a moderator band, we have the left ventricle, we have the right atrium and the left atrium with the pulmonary veins connected by the foramen ovale. And we also see behind the left atrium the descending aorta and downwards the spine. The next plane that needs to be evaluated is the 5-chamber view, or the left ventricular outflow tract, where we see the right and left ventricle again, but also we see the aortic root, right atrium, left atrium, and again the descending aorta and the spine. The next plane that needs to be evaluated is the right ventricular outflow tract with the mean pulmonary artery and the right and the left pulmonary artery. And Then the last plane is the so-called 3-vessel and trachea view, where we see the connection of the aorta and the pulmonary artery and the ductus arteriosus. Behind the aorta, we see the trachea and also the superior vena cava. So ISWOC says that there has to be evaluated 5 planes. When comparing these guidelines to the guidelines of the AIUM, here they propose even more planes. We have again the axial planes like we've seen before in the ISWOC guidelines, but the guideline has also some sagittal planes like the cava views, the aortic arch and the ductal arch, and also the high short axis of the right ventricular outflow tract, as well as the low short axis to evaluate the right and left ventricle. And we also see here the typical pattern that the right ventricle appears like attached to the left ventricle. However, when we look at these kind of guidelines, there's one big problem, and this is a really significant issue. It doesn't matter whether we evaluate still images or whether we evaluate clips. And you can also add to the clips a sweep where you start at the 4-chamber view and go upwards to the fetal head to evaluate the left and right ventricular outflow tracts, and finally ending at the 3-vessel and trachea view. The issue is that we never see the different planes at the same time. And this problem or this issue is solved by the wonderful technology that has been developed by Gustavo, the FINE, Fetal Intelligent Navigation Echocardiography. He already showed us how it is applied, but here we have a stick volume. We use this list of the 7 clicks, and then from this volume data set, the different examination planes are extracted and can be evaluated afterwards. So here an example like we've already seen from Gustavo. We have the 3-vessel and trachea view, we have the 4-chamber view, 5-chamber view, left ventricular outflow tract, the short axis of the great vessels, then the abdominal view to assess whether fetal right and left are correct here with the stomach shown. We have the ductal arch and we have the aortic arch, and finally we have the vena cava draining into the right atrium. I brought you some cases, 3 cases to demonstrate the value of FINE. Let's start with the cases. This is case number 1. So even if you're not familiar with fetal echocardiography, when you're used to the different examination planes, and maybe if you have applied FINE to stick volumes in the past, you're immediately aware that this image looks somehow abnormal. And to be honest, this is in many cases already more than enough, because the correct identification and classification of different cardiac defects is not important for for most of the screening units. It's just important to identify those fetuses so that they can receive an expert examination, and also the planning and management of the ongoing pregnancy, and of course of the delivery, because fetuses affected by congenital heart defects should be delivered in a hospital with pediatric cardiologists and cardiac surgery available. So let's have a look at our volume here. I marked the different planes that have an abnormal finding. And here it's actually quite easy because all planes except the abdominal view appear abnormal. So let's go through the different planes. Let's start with the most obvious finding we have in this fetus, highlighted here in red, a marked cardiomegaly. So usually the heart should be approximately, or should cover approximately 1/3 of the thoracic plane, but here we see it's much bigger. It appears like that almost the half of the thorax is filled by the fetal heart. What else can we find? We see an abnormal cardiac axis. Usually the cardiac axis should be around 45 degrees, but here we see it's much more. It's probably around 60 degrees. Here, indicated by the red arrows, we have an enlarged right atrium. You see it here at the level of the 5-chamber view as well as the level of the 4-chamber view. You see the enlarged right ventricle also here in the short axis, but you also see it here in the cava view where the inferior and superior vena cava drain into the right atrium. But we also see that the pulmonary valve, beautifully visible here in the 3-vessel and trachea view and in the short axis view, appears somehow dysplastic. It's very echogenic. And finally, if you look carefully, I hope it is the enlargement works now in the transmission, you see that there where the yellow arrow is, that there is some tissue moving a little bit deeper from the connection of the tricuspid valve. So it appears that the tricuspid valve is somehow attached more into the direction of the cardiac apex. You can use fine in the normal B mode, but you can also acquire volume with a color Doppler. And we beautifully see the turbulent blood flow, especially here in the region of the tricuspid valve and the right atrium. But when we see, and when we have a look here at the position where we expect the anterograde flow from the pulmonary artery, we see a reverse flow. So apparently the ductus arteriosus has a reverse flow because the pulmonary valve is somehow impaired. So the diagnosis of this finding is Epstein's anomaly, and the little structure I've shown you with the yellow arrow was the displaced tricuspid valve. What do we know about Epstein's anomaly? It was first described by Epstein in 1866, and the septal and posterior leaflets of the tricuspid valve are displaced toward the apex of the right ventricle, as shown here on the pictures. Here in the lower 2D image, you see the tricuspid valve here in another fetus with attached and positioned more to the cardiac apex. And it results in a failure of tricuspid valve delamination, annulus dilatation, and highly variable tricuspid valve morphology. Typically, as we've seen it also in our case, is a severe tricuspid regurgitation. And the frequency varies between 1 in 10,000 and 1 in 50,000. So let's go to our next case, case number 2. Again, we have a volume from fine extracted a stick volume, and we see also here an abnormal impression on visualization of the planes. Again, mark the planes that show abnormal findings. The most obvious findings in this case is a ventricular septal defect. You see here at the level of the 4-chamber view, the defect, and it's also beautifully visible at the level of the left ventricular outflow tract. So what else do we see? When looking at the 5-chamber view and the left ventricular outflow tract, we see that the valve and the outflow tract is positioned above the ventricular septal defect. And what comes up here very beautifully is that besides the ventricular septal defect, the 4-chamber view looks from the size of the ventricles quite normal. So it is important to have the segmental approach to see the 4-chamber view and the vessels here at the same time. So we have an overriding aorta. What else do we have? We have a very thin and narrow right ventricular outflow tract. Here also color Doppler fine volume was available. So again, we are able to see the VSD. And beyond that, we have again the overriding aorta, especially here in the 5-chamber view plane, beautifully visible, but also here again in the left ventricular outflow tract plane. But also we see here with the green arrows a very narrow and thin right ventricular outflow tract, also here in the short axis and in the ductal arch plane. It appears like it is interrupted, but that might be also an artifact. But the blood flow, especially the diameter of the right ventricular outflow tract, that is supposed to be approximately the same size or even 1/3 bigger than the left ventricular outflow tract, is clearly abnormal here. So the cardiac defect we see here is a tetralogy of Fallot. The known prevalence is approximately 4 in 10,000 live births, approximately 7 to 10% of all cases with congenital heart defects, and the correction should be performed within the first year of life. It's equally distributed between male and female newborns. And what we also have to keep in mind is that it is in approximately 15% of the cases syndrome associated, especially Down syndrome, Alagille syndrome, or the DiGeorge syndrome. So let's come to our final case. And when looking at this case, there are certain similarities to the previous case. Again, I highlighted the planes that have abnormal findings. And what is obvious here again is that there is a ventricular septal defect. You see it in the 4-chamber view plane, it's visible in the 5-chamber view plane, but also in the left ventricular outflow tract plane. What else do we see? Here with the white arrow, with the yellow arrow, we see a very narrow, almost non-existing right ventricular outflow tract. So it's barely visible. It appears also in the ductal arch view, you cannot visualize the right ventricular outflow tract. It appears like the right ventricular outflow tract is missing. Also here was a volume with color Doppler available, and here it comes out much more beautiful. when looking at the right ventricular outflow tract, the outflow tract is missing. There is no right ventricular outflow tract. But however, somehow the blood has to get into the lungs because otherwise the circulation would not work. And the solution is also available, or the explanation is also available in this volume data set. And this comes up with the next arrow here, with the arrow in the aortic arch plane. If you look carefully at the tip of the arrow, you see a little red signal going upwards. And this is the clue what this cardiac defect is about. So I'll come to the next plane where I will explain which defect is. We have here a case of pulmonary atresia with ventricular septal defect, so a PAVSD. What do we know about this defect? The prevalence is approximately 12% of all congenital heart defects. And compared to the previous case, the major difference between tetralogy of Fallot is the presence of a normal pulmonary trunk and arteries in tetralogy of Fallot. In our case, there was no pulmonary trunk. So the right ventricular outflow tract was missing, and the blood was entering the pulmonary circulation through a certain vessel. It's called major aortopulmonary collateral arteries, or so-called the MAPCAs. And here is the corresponding B mode and color B mode, color flow Doppler imaging. You see the vessels arising from the descending aorta. So in conclusion, what do we know? Congenital heart defect detection is important. Why is it important? Because it affects the future outcome of the pregnancy prenatally as well as postnatally, because it affects the treatment success, but also it gives the option in some cases, at least, to discuss termination of pregnancy. What we also know for many years is that if congenital heart defects are prenatally detected, there is a significant reduction of morbidity and mortality in the newborn, and screening for congenital heart defects is a reliable method for the early detection of especially critical pulmonary, critical congenital heart defects, and even non-cardiac conditions. So I'm looking forward to the next lecture. Jan Weichert and I, we are, by the way, not brothers, although many people think we are brothers, but we have many similarities. So our grandparents used to live approximately 20 kilometers far away from each other, although we did not find out whether they were somehow related. It's probably not that far away from that they grew up from each other. So there is a possibility that we are related. And interestingly, our daughters have also the same name, but we also published two very beautiful papers, I think, about the right heart and left heart anomalies. So with this picture, I'm coming to the end, and thank you for your attention.
Thank you so much, Professor Alexander, for your outstanding lecture. And of course, you're absolutely right. As soon as we will put a diagnosis, we will know a prognosis and we will make right decision. Thank you so much. And I ask you to remain online for the discussion. And I want to invite next speaker, Jan Weichert, who is a head of prenatal medicine, special obstetrics clinic for gynecology at Obstetrics University of Lübeck, Germany. Please.
Yeah, yeah. Hello, everyone. Thank you for this kind introduction and the invitation for this web course. I'm very delighted to participate in this course, and I will start with the left heart anomalies. I hope my screen is seeing well, and my talk is going about the dilemma of diagnosing CHD prenatally, and I will just switch to the anatomic reconstruction using FINE, and I will explain on certain cases of left heart anomalies. I will start with a slide with Alexander's last slide, which shows you the impact of diagnosed and even non-diagnosed congenital heart disease. And this is what we face in reality. We are not really good in detecting heart defects in the non-selected population. And when we go to the left heart anomalies, we are slightly better in diagnosing the hypoplastic left heart, but we are at least not that good in diagnosing coarctation. And I will show you why, and I will explain it on some cases. In general, the explanations for the not optimal detection rates of congenital heart disease are depicted in this both papers. And to sum up, there's a lack of adaptational skills to play that appear to play an important role in undetected CHDs, as opposed to circumstantial differences like BMI or fetal position. The quality of the cardiac views might be the main trigger for these undetected cases. What is the problem? We all know that there are some difficulties in diagnosing CHDs, and we all know cases in which our image on the screen is not that better, as you can see here. But what is the problem for the non-experienced case operators, and I really argue that these schematic drawings will help them to get into depth in diagnosing a normal and abnormal heart as a highly sophisticated 3D and even 4D structure. And what we need, and Alexander already told this, we need different planes of cardiac views to get a comprehensive impression of the integrity of the heart. You see all the 9 planes which are claimed and warranted by the national and international guidelines you see here. And this constitutes a complete echocardiogram, and this is what we aim to realize during our examination of the heart. And just to make clear what we do during our examination, you see on the right-hand side the conventional 2D echocardiography, and on the left-hand side, this is a volume or preparation for acquisition of a volume, and this volume harbors any diagnostic plane, but this is difficult to, as we all know, difficult to retrieve all the diagnostic planes out of that volume. But the very smart solution is the FINE software, which is semi-automatically depicts all 9 planes in one template, and this is the absolute advantage compared to the conventional 2D ultrasound of the fetal heart. And just to this, even at the risk of redundancy, I will show you what is this all about. You see all the 7 points, and when you mark those points here, as you see here, you will get you are guided through the volumes, and the FINE software shows you what the images look like, and you can see here the planes. And what I'm really thrilled as I saw this for the very first time was the congruence of those planes with a macroscopic schematic template, as you can see here. And this is what we use every day in our clinical practice when we start to examine the heart. And so we are now heading towards the left heart, and the colleague here in 2006 it really warrants that everyone who goes into the left heart or in the cardiac structure should be familiar with a ventricular structure and function. And you can see here when we have a look at the left ventricle, you see there's a narrower and longer structure than the right ventricle. There's a gradual thinning of the left ventricle wall towards the apex. There are two papillary muscles that originate from the left free wall of the heart, and they are attached to the mitral valve chordae. And this is what explains that most of the left heart problems and anomalies occur on both the aortic valve and the mitral valve. And the left ventricle primarily perfuses the coronary and the cerebral circulations through the ascending aorta. When we look schematic on the structural heart anomalies, you can see that there are a number of structures who might be affected, and in most cases there are affected structures which are depicted in a lot of or in many of those categories here. And this implies that we need a number of differently orientated planes to cover the whole heart and get an impression of the whole heart. And when we look for the left heart anomalies, we all know that there is a correctation of the aorta and aortic stenosis and hypoplastic left heart. You can see here the prevalence of those anomalies, and this is what I want to show you during the next slides. Okay, we have already experienced that FIND is able to cover nearly all anomalies of the fetal heart, and this has been published well in the literature already. But we have to bear in mind that 2D ultrasound remains the method of choice in diagnosing congenital heart defect. But as Gustavo and Alex already explained and showed, the FIND software will give you an additional impression and will raise your confidence in diagnosing the anomalies, and how these reconstructed planes depict the very specific anatomy is shown here. You see the left ventricular outflow tract in normal fetuses, in right heart anomalies, in hypoplastic left heart, and even in complex anomalies as the double outlet right ventricle. When we go back to the left ventricular anomalies or left heart anomalies, you see that there's always a certain combination of atresia and stenosis and combined stenosis, and there's this is an approach which shows you that when you have a combined atresia, which resembles the classic form of hypoplastic left heart, you have a hypoplasia of the appendages, you have a slit-like left ventricle, you have an rather unusual endocardial fibroelastosis you have very, very narrow ascending aorta and coarctation, which means a hypoplastic aortic arch is very usual compared to the combined stenosis, which are not that easy to diagnose in certain cases. You see here, and left ventricular morphology may vary, and the fibroelastosis is really common compared to the classic form. And yeah, this is what I want to show you in these slides. You have on the very left side the normal heart, and you see here a tiny hypocontractile left ventricle, and these are cases of a endocardial fibroelastosis in different presentations, and this might guide you to the diagnosis. And what you have to cover when you approaching left heart anomalies, you have to get to know how the intraatrial septum looks like. What about the mitral and aortic valves patency? The tricuspid and pulmonary flow has to be checked. The size of the aorta and the flow over the aortic valve has to be assessed. The aortic arch anomaly. And you see here, this explains or shows you that you need a number of different planes, and we need a number, not only a number of different planes, you need a number of correctly orientated and correctly depicted planes, and this is not always easy to achieve, and this is rather difficult even in the non-experienced hands. And this is where FINE has its absolute advantages. When we go through the cases, we have an aortic arch, an aortic stenosis. What is we start always with the 2D. I have here on both sides here a conventional B mode clip, and it added color. And when we start our FINE software, you see here that on this slide you see in the 3-vessel view there's a tiny aortic transverse aortic arch. You see here there's a ventricular discrepancy, and you can hardly or barely see a nice aortic arch, and this shows you that there is a ventricular discrepancy. There's a laminar flow towards into the both ventricles, and there's a laminar flow which you already saw on the color flow image. There's a laminar flow through the aortic arch above, and when you see on the bottom, on the middle image on the bottom, you see there's a hypoplastic aortic arch, and this is a tubular aortic stenosis. And when you see here another case, you see that not that strikingly obvious discrepancy of both ventricles. But what you can see is on the 5-chamber view on the left ventricular outflow tract, there's a non-disappearing aortic valve. You have a normal right ventricular outflow tract, and you see a rather tiny aortic arch, and this is aortic stenosis, which we published in our already mentioned paper. And this is on the contrary to this, you see a severe aortic stenosis. You can see here on the left-hand side a triplanar image, which gives you a first impression, but you cannot figure out anything because you are not able to see the outflow tracts because this here's a shadowing of the rib. But on the lower panel, you see the disturbed inflow on the left side, a hypocontractile left ventricle, and when you reconstruct this with fine, I have to apologize for the image quality, but this was a 31-weeker, and you can see all information you will need to finalize your diagnosis. You see a thickened aortic valve, very small left ventricular outflow tract, hypercontractile left ventricle, as we already saw. And when you have a close look to the aortic arch on the bottom, you see also a hypoplastic aortic arch. And this will finalize your diagnosis of a severe aortic stenosis, of a critical aortic stenosis. And this is what might or enables you to counsel the patient properly. These are three other cases of a abnormal four-chamber view, and we go through this. And the first one is again a ventricular discrepancy on the upper panel. You see a small transverse aortic arch on the three vessel view. I enlarged this. You can see here this a transverse aortic arch. When we go to the four-chamber view, you see the discrepancy of both ventricles. You can barely see the aortic arch in the aortic valve on the five chamber view. And when we just see here, the aortic arch is very small, very tiny, and this was a case of an coarctation of the aorta. The other, compared to this, you can see, we already saw a similar case. We have a small, tiny hypercontractile left ventricle. We cannot really see the aortic arch is very tiny in this part of the image. And this was as we saw already, a hypoplastic left heart. Okay, this file we gonna skip right now, and we go back to the hypoplastic left heart. This is the case when we start with a 2D ultrasound. See, there's no inflow in the left ventricle. The left ventricle is very round shaped, very small, and endocardial fibroelastosis is present. You see on the lower panel, there's a reverse flow across the transverse aortic arch. And when you directly visualize the aortic arch, there's a very tiny structure compared to the ductal arch. And when we reconstruct these, this volume, as you can see here, is the same patient. You can see all the structures and all the things we already saw in the 2D image, but nicely displayed on one template. There's a small aortic arch on the bottom. You see the hypercontractile small left ventricle, the small aortic arch, the small aorta, ascending aorta in the five-chamber view, in the left ventricular outflow tract, and the right outflow tract is not affected. And that nicely shown hypoplastic left heart. And this is another case. You see here, there's might be a single ventricle circulation, but when you slightly rotate the transducer, you see on the bottom of the screen, there is a very thin slit-like left ventricle. And this is what you nicely can depict in this image. And we have a very, very, very small aortic, transverse aortic arch in the three vessel view. And you see here the slit-like a hypoplastic left heart, and this is the classical form of hypoplastic left heart, resembling mitral atresia and aortic atresia, and finally resulting in a slit-like hypoplastic left ventricle. And this is what you can nicely depict in this 9 template image. Another case of a coarctation, which is barely seen on the bottom video clip, but when you switch on the color, go to the 3-vessel trachea view, you see there's a smaller aortic transverse aortic arch. When you visualize directly the aortic arch, you see here there's a coarctation present, and this is what you see and what you can recognize on the 9 image display. There's a small transverse aortic arch in the 3-vessel trachea view, and in the there's a small aortic arch directly seen with an aortic shelf as well. Another case here, you see again a small aortic arch. When you visualize this directly, there's an additional muscular ventricular septal defect, and this is the resulting image in fine reconstruction. You see a small aortic arch on the bottom, is the ventricular discrepancy. And I just come to the end of the talk, and I will finally show you some other images, some other fine cases. This is also being published in our paper here. You see, although there's the problem is on the right side, because we have a small right-sided ventricle. This is what I wanted to show here, a double inlet left ventricle. You see the both valves opening in the anatomical left ventricle, and the small right ventricle is seen here. And this is the case of a so-called Holmes heart, and the problem was a double inlet left ventricle. And this is another case. You see here the problem is obviously predominantly on the right side. I will just show you this. I'll start again here. You see here there's a atrialization of the right ventricle, but, and this is what Alex already showed you, we also have a small aortic transverse aortic arch, and we can barely see the aortic arch on the bottom here. And this is a tubular aortic stenosis in conjunction with an Epstein anomaly. And this is what you can readily depict on reviewing these pictures here. Epstein's anomaly plus aortic stenosis. So another case, you see here a slit-like left ventricle, but the problem is not the small ventricle, left ventricle itself, but there's a complex heart anomaly. You can see here there's a origin of both large vessels originating from the right ventricle, and this is a double outlet right ventricle, and you can recognize this in these images as well. My personal perspective, to come to the end of the talk, is that we are in the future, we might use these automatical reconstruction, maybe even in earlier gestation. You see here is a case, a 3-planar reconstruction of a hypoplastic left heart at 10 weeks. And maybe we can, in the future, reconstruct those cases. As you can see on the right-hand panel, there are left heart anomalies, and this is what our goal should be that the diagnosis may be extended in the first trimester using a standardized approach as exemplified with FINE. This is what I want to show you on my very last slide. This is a coarctation at 14 weeks. You can see this is a hydropic fetus. There's hydrothorax, but also a hypoplastic left heart and tiny left heart structures. This was a case of a Turner syndrome. And I want to thank those teachers of and even inventors of FINE. We are lucky to visit Roberto Romero and Lamouille in 2016 in Detroit, and we are always lucky when we see Gustavo in our meetings on different congresses, as we last did in London this year. And to close this lecture, FINE is an excellent tool for simplified volume navigation and plane reconstruction. This is definitely an adjunct for exact diagnosis. It might aid a cardiac anatomy assessment, as you saw in these images and clips, and this leads finally to an improvement of sensitivity and specificity. So this, I hope I did not confuse the audience, and I want to announce our first German Congress on prenatal artificial intelligence in prenatal diagnosis, which is postponed to May next year. And maybe we can see you in Cologne, and thank you for your attention.
Thank you very much, Jan. A very nice presentation highlighting all the potential of the FINE. It was very nice to see your picture with Alexander at the PRB, where I am now, and with Alami also. I recall to the participants that if you want to see something more, there is a special YouTube channel of Alami Yeo, where there are, they described all the FINE and the FINE possibilities. I substitute the chairman at the moment because the chairperson is going to speak, so I have to introduce her. Jan, remain online for the final discussion, please. And I'm very happy to introduce Valentina Zivisova, which is Chief Fetal Surgeon and in Almazov Perinatal Research Center of St. Petersburg, but she lives now in Italy as ultrasound specialist and a member of the Preis International School, where she helped to organize courses, particularly on ultrasound, aesthetic, and ecology. She will address a diagnosis of some challenging anomalies. So please, Valentina, and then you follow up with the chairperson, okay, of this meeting. Thank you.
Thank you for nice introduction. I'm going to share my screen. Okay. Good afternoon, dear colleagues. And I'm going to speak today about diagnosis of challenging heart anomalies, because despite of a lot of information of mechanism of information of heart anomalies, despite that we have a very sophisticated machine nowadays, we still have a low prenatal diagnosis in some of them, which increase mortality. And I speak about challenging heart anomalies, coarctation of the aorta and transposition of great arteries. And because this malformation has very low rate in detection, and this had been shown in systematic review in 2019, that some centers have a very low detection around Europe and In Canada and the USA, some centers has higher detection. For instance, in France, they show one of the biggest result in coarctation of aorta. But if to look for this ratio, you can see that is in many countries are very low. And why is needed to detect before? Because all of these pregnancy deserve to be sent it to the tertiary cardiac center in order to receive soon after birth infusion of prostaglandin, because these pathology are ductus arteriosus dependent, and to get, of course, a planned surgical correction of this pathology. So we classified 3 types of coarctation, which is most frequent detected. One is a preductal coarctation, and this kind of malformation is much easier to detect because we have a 4-chamber view, and in this 4-chamber view we can see how is arch hypoplastic. With the second and third is much difficult, because this part of aorta is really difficult to obtain in some cases, and also because this kind of coarctation can happen only after birth when ductus arteriosus is closing. So, and if to underline the causes of coarctation of the aorta, we have 2 most popular theory. One of these is linked with the ductal tissue encircling the isthmus, and when this baby is born, ductus arteriosus normally is closing and also narrowing this part of the isthmus. And second theory is linked with a situation which change hemodynamics in left part of the heart, or decreasing left output or left ventricle feeding, or instead increase hemodynamic circulation in right side. This can be a cardiac malformation or extracardiac malformation. Also, we have to keep in mind that there are genetic causes, because third of this pathology are linked with chromosomal anomalies, and most frequent is the Turner syndrome, trisomies, DiGeorgi, and as I mentioned before, 20–40% of extracardiac structural pathology bring these hemodynamic changes in the fetus and form coarctation. Right suspicions of coarctation when we see a ventricle septal defect, when we see a mitral anomalies, left ventricle outflow obstruction, or when we find a complex of congenital heart disease. Also, it's very frequent bicuspid valve, but prenatally is quite difficult to obtain a right view to find this pathology, and usually is postnatal findings. So let's start with prenatal diagnosis with disproportion of ventricle size. This is not direct marker, but if we find before 20 weeks, this will be very producible, because in 80% we will find coarctation of aorta. As you can see in this slide, this is 14 weeks. Is quite obvious that the right side bigger than left side. Is not difficult to recognize, but after 28 weeks, this opportunity are decreasing of this marker, because is related only with the 25% of coarctation of aorta. So why this discrepancy happened? Because left ventricle is feeding by right to left shunting across foramina valley, and left ventricle ejects to ascending aorta and coronary arteries and bring blood through the arch to the neck and head vessels. But isthmus receive from combined cardiac output only 10–15%. And of course, when it's decreasing feeding of left ventricle, decreasing left ventricle eject, this can affect and create in isthmus coarctation of the aorta. But when coarctation of aorta is primarily and diastolic pressure is very high, and this decrease right to left shunting and increase load in right ventricle and make right side bigger. So I think this disproportion of ventricle size, because is presented in a large number of normal fetus, is underestimated many times, and people decrease in prenatal diagnosis, has decreased low level of suspicious when they saw discrepancy of ventricles. And I want to show you one case, which is I had many years ago when I worked in screening area. This is a case at 12, despite it is not so good images, you can see that at 12 weeks was disproportion, at 16 and 20 weeks. And I already in the beginning wrote that can be a coarctation. In 16, I was confident that is a coarctation. But because of, let's say nowadays, possibility to go for the second opinions, and this lady went for commercial center, for other experts, for pediatric cardiologists, they convinced her that everything is okay, discrepancy can happen, nothing wrong. And even when she came in 31 weeks, she showed that they say that yes, is a right ventricle dominance, nothing wrong, it happened. But you can see in this last video that is a really coarctation of aorta, and this was another matter of challenging. I tried to convince her that she should go to deliver in a tertiary cardiac center, and fortunately she followed me, and everything in this story and with happy end. This guy was operated, and now is a strong, big guy. But I think it's also kind of problem in diagnostic of coarctation of aorta when we underestimate this discrepancy. So come back to prenatal diagnosis, and next marker is in a third vessel's view we can obtain. We can evaluate aortic arch, and we can evaluate the isthmus, and we can evaluate the pulmonary artery. And you can see that in aorta, in case of coarctation, aorta will be smaller, 2 times smaller than pulmonary artery. And also in the second trimester, you can see it better that aorta is smaller. I want to draw your attention that in simple coarctation, flow will be antegrade, not like in hypoplastic left heart syndrome, because despite that size of the cavity is smaller, is function is preserved and is enough to make antegrade ejection. Left superior vena cava can be recognized also in free vessels view, and this is also not a direct marker of coarctation of aorta, but because of draining, left superior vena cava is draining coronary sinus, and this is a hemodynamic diversion away from the left ventricle, and this affects left atrium compliance. This can lead to formation coarctation of aorta, and in 21% of left superior vena cava, we can find the coarctation of aorta. If we are lucky to obtain a long axis view, this is really difficult, especially in advanced gestational age. We can see that aortic arch will be not perfectly twisted, and we will see that left superior artery can be displaced. I think this is important to ask yourself when you make a heart evaluation, how does look the heart? Because in healthy heart, all images, all view are perfect. And the aortic arch should be perfectly twisted. If it's not, try to find a problem. So as I mentioned, long axis view is not so easy in all cases, and sometimes can be a problem because ductal arch can close the aortic arch, and we can lose these images and to make a not correct diagnosis. So in these images, we see correct, very small aorta. So there are also other markers which has high sensitivity, high specificity, and they're very, very good in detection coarctation of aorta. But when we will use it. If we work in screening area, we will use it only when we already have doubts that can be a problem with aorta. Just because everyone will to calculate, we haven't time and is not needed. First, we have to get some suspicion that can be possible an anomaly in aortic arch. So now let's move to the second one. This is one of the difficult in a prenatal diagnosis, transposition of great arteries, especially if you work in a screening area, because not 4-chamber view will tell us anything, not 5-chamber view will raise the suspicious, and this is really difficult for prenatal diagnosis in screening area. For me and for my colleagues who work in a biggest cardiac center is much easiest because we are like a team of last opinion. For us came patients with already malformation, with already put a diagnosis, and I suspect to see this malformation. But I think all of us has to be suspicious in each case they evaluate, and also to know characteristics of these malformations. So as I said, is underdiagnosed and the diagnostic rate is less than 50%. Why is so important to detect before? Because it's also required to deliver in tertiary cardiac center, where there are facilities to perform a prostaglandin infusion, and if it's needed, to perform emergency Rushkin procedure. We know complete transposition of great arteries, characteristics are that there are ventricular arterial discordance and atrioventricular concordance and parallel relation of great arteries. We will discuss about dextra transposition of great arteries, and morphological definition is that aortic valve is located in front of the pulmonary valve. There are simple transposition, which is not associated with cardiac anomalies, and can be in a complex with other cardiac malformation. So this anomaly is the most common cyanotic congenital heart disease. Is not associated with chromosomal anomalies. It may have multigenetic origin, and in literature you'll find that there are in maternal diabetes cases, is linked with maternal alcohol consumption. There are a role of pesticides, of history of retinoic acid use, but in my own experience, my patients haven't such background. Simple dextra transposition, which is much more frequent presented, has intact ventricle septum or hemodynamically insignificant ventricle septal defect. Complex dextra position has a moderate or large ventricle septum defects, and of course, in a third of these cases, there are obstruction of the outflow tracts and atrioventricular valve pathology. So prenatal diagnosis, we start with evaluation of the solid situs, and in these cases, situs will be or solitus or inversus. In this case of transposition, you can see in a video that everything is situs solitus, everything is okay, visceral organs are located normally. 4-chamber view also doesn't bring any information. You can see that size of the heart is normal, apex is left orientated. You can see morphology of the ventricle, right in a right side, left in a right or in a posterior side. We can see a pulmonary veins, which tells that this is a left atrium. So everything is like in a normal heart. Outflow tracts, and this we start to see something. What suggests our guidelines to use a 4-chamber view, but 4-chamber view, in fact, doesn't show us which kind of vessels is rising from this ventricle, and I suggest to prolong this 4-chamber view before we will not reach a bifurcation of some of the vessels, and after we have to ask ourselves from which ventricle this vessels is rising. As you can see in this video, bifurcation is in these vessels, and this vessel rise from the posterior ventricle, which is the left, and aortic arch is rising from the anterior ventricle, which is right ventricle. So when we obtain such image, we understand that is already discordant connection. And only after that, just to confirm that is transposition, we will do this kind of view, let's say semi-longitudinal, because it's not really a longitudinal, just to see the two parallel course of these arteries. And in the last beautiful image, you can see automatic reconstruction of done by stick, and this was presented in one of the study of Professor Ritze, where all transposition cases with transposition had been recognized by this system. That is a very beautiful image, and is very useful, I think, when we have already suspicious that can be a transposition, and for confirmation, I think is very good. So free vessels view. In this view, we will see a characteristic of transposition, and here I marked what will be. We see that aorta, which is rising from the left ventricle, will be in front of all vessels. Usually they stay in one side, in one line, but in situation of transposition, aorta is going in front. If you go a little bit careful for free vessels trachea view, we will see not typical V sign of ductal and aortic. We will see only two vessels. We'll see only aortic arch and superior vena cava, and ductal we don't see because it is below aortic arch. In a work of Palatnik was shown that this he called it I-shaped, was presented in almost 97% of cases. So this slide represents creativity of prenatal diagnosis and show how people created terminology, which I think is also very useful, because we, like in prenatal diagnosis, have to know many other malformation, and the majority of them are described like in free vessels view will be 4 vessels or 2 vessels or 2.5 vessels. And of course, to memorize all of this is quite difficult. But when you have a good fantasy and you can linked with some association, this I think work very well. Despite all of these markers are done in the same free vessels view. And when you see asymmetry of the chambers, you can understand that you have a complex of transposition of great arteries. That means that is ventricle septal defect, and location, size, and relation with great arteries have to be defined, because after, if there are a shifted of this septum in let's say in front of toward pulmonary artery, this can lead to subpulmonary stretching and to create subpulmonary stenosis. If it's shifted toward aorta, this can lead to formation of hypoplastic aortic arch and coarctation. This, dear colleagues, can be seen like I show you nothing new, that all of this is the basics, and already everybody know how to scan transposition of great arteries. But I want to show again, third slide, to show that not everybody is able to detect coarctation of aorta so precisely and transposition of great arteries around the world. Only one leader is France and some centers in Italy, but majority of our world has very low detection rate of these anomalies. But these anomalies require to be detected before delivery. So in conclusion, I want to say that prenatal diagnosis of coarctation of aorta and transposition of great arteries may have an impact on postnatal outcomes and therefore require planned delivery and prenatal management. And I want to end this quote from Holy Scripture: "We don't see things as they are, we see things as we are." Thank you for your attention. Now I want to invite next speaker, Rabbi Shaoyu. He is a director of Center of Ultrasound and Human Genetics in Berlin, in Germany, and is past chair educational committee of ISWOG and is recipient of many awards. Thank you.
Thank you. Thank you, Valentina. I hope you hear me well.
Yeah, I hear you very well.
I have a problem with the technique here. I'm sorry. Okay, let's start. I will share my screen, and so wonderful talk. Congratulations. And so I will start now with my presentation. And as I said before, I did not know what you will be showing, so I apologize that I will have also part of transposition. And so I decided to give a talk. Sorry?
More we will see, better will be.
Yeah, okay, thank you. So, and then you see, I hope my screen. So I decided, because the previous speakers were speaking mainly on the four-chamber view, to go to the great vessels and to work with you together on the symptom, how to get to the diagnosis and the disclosures. I'm getting honoraria from G Healthcare, not for this talk. So I will decide today to cover with you rapidly two diseases. One is the overriding of the aorta, two group of diseases, and the other one is the parallel vessel course. And I want at the beginning to quote Magritte, for the one who know modern art or Dada art. Magritte showed this image and wrote, "It is not a pipe." And in other words, let's say in the modern language of computer, you will say, what you see is not always what you get. It's not vis-a-vis. This is why follow with me and we'll see what I mean. So when we look at the four-chamber view and we move step by step toward the great vessels, we are checking the five-chamber view or the left ventricular outflow tract, and we look at mainly for four things. We look if there is a perimembranous VST, if there is an stenosis of the aortic valve with, let's say, thickening and turbulences. And the main hint, I think, is the overriding of the aorta over a VST. And what people are often forgetting, and this is why I like very much the way you approach, Valentina, that is the vessel arising from the left ventricle really the aorta, or could it be also the pulmonary artery? So come with me now, and let's take the first group. The first group is the overriding of the aorta. It is not a diagnosis; it is a hint. It means this is the first step. What we'll detect, and there are two typical things we may see. We may detect a VST, and when you see the VST, an outside VST, you should ask yourself: is the aorta normal or is it overriding? Now, the second part is, if you look at carefully here, because the aorta is getting blood from both ventricles, it is automatically so that it is slightly larger. So sometimes a dilation of the aortic root may be the first thing before even seeing the VST. And this is Etienne Fallot. He described exactly 130 years ago, 1888, this disease. But actually, it was described even the 600 something. But he gave it a name, and he gave it four signs. The typical signs are the VST, the overriding of the aorta, and the pulmonary stenosis, and in addition, an hypertrophy of the right ventricle. So these are the tetralogy of Fallot. In the meantime, we know that the last one, the hypertrophy, is not present neither prenatally, not early postnatally. It was present when people were getting adult or they were dying, and the squatting baby getting an operation at 5 years of age. This is why prenatally and early postnatally you have a trilogy of Fallot, which means the four-chamber view is normal, but the five-chamber view and the pulmonary artery will be abnormal, but not the right ventricle. So this is why, keep in mind, these are the typical signs. So in other words, next time you see an overriding of the aorta, you will automatically think, because the word overriding is part of the disease, and this condition is quite common, it's going to be a tetralogy of Fallot. But And I would recommend you, first of all, to use the color Doppler, because the color Doppler shows you that really blood flow is coming from both ventricles into the aorta and not only on one, let's say, no intact septum. And yeah, from this point of view, I think it's important to follow, and the diagnosis can only be made if you are able to demonstrate the pulmonary artery arising and separately and having an antegrade flow, showing this discrepant size. So in general, you know, pulmonary artery is larger, now it's narrow. In general, it is in these cases not entering in the side by side, but on the side of the aorta. You see, it's like a letter Y rather than letter V. So, and then this is then how we have it. I'll show you here a stick where you can see from the 5-chamber view towards the 3-vessel trachea view how the narrow pulmonary artery is, let's say, obvious in comparison to the aorta overriding and dilated in the background. This is tetralogy. Now we move to the second disease. If you look at the 5-chamber view, it looks similar actually, because there is a VSD and overriding of the aorta, but the pulmonary artery is closed, and it can be closed, it can be even absent. And this is disease is called pulmonary atresia with VST. Actually, this was in the past considered as a severe fallow. In the meantime, it is considered as a separate entity because it is general by far more severe, and it can even not be operated in some conditions, and it's too complex. Embryologically is also different, let's say, conditions. So, what do we see? Actually similar. The first step is similar. If you have seen many cases, you notice that in pulmonary atresia with VST, the aorta is even larger, because in tetralogy you have some of the blood going to the lungs. Here you have the whole blood from left and right going into this vessel. So the aorta is significantly larger, but this is not, let's say, not so obvious that you can know the diagnosis, because you don't see 5 cases on the row, 3 tetralogy and 2 like this one. But this is a kind of hint that means you may have aliasing at this level. Now you will struggle in order to demonstrate a pulmonary artery, but you don't find it because it's so small, and in general, since the embryology underdeveloped, it is hiding under the aortic arch and tortuous. So this is why in the 3-vessel view, you see 1 vessel. And many people, most cases refer to me for this condition, they assume it is a common trunk because they see 1 vessel. No, what you should do here is tilt the probe to get the sagittal view, and then you see that under the aortic arch there is a reversal flow. Here you see the red part and getting into the lung, and this is the demonstration of these tortuous ductus getting blood into the tiny hypoplastic pulmonary arteries. And I personally prefer to get this almost sagittal view to demonstrate the enlarged aorta on one hand, but also the reversal flow to demonstrate this retrograde flow. And in this view, I look a little bit further downward, and I see here some additional vessel, which is the MAPCA Alex Vaishnav was speaking about. So the MAPCAs are a typical disease for this condition. They are present 20 to 50% of this disease. Actually, if you see the MAPCAs, you know straightforward, it has to be a pulmonary atresia with VST. It is, it should remind you like the arteries of the bronchopulmonary sequestration without having echogenic lung. You see an aberrant vessel going out. So if you see now here on X-ray of a fetus, I scanned prenatally and this is postnatally how it looks like, then you know when you are looking to them. And you see here they are in general at the level of the 4th view almost. This is where they should have gone into the lung. You see here we have the ductus arteriosus, but then the other one. And I will look at them in this way when I'm looking to the lung veins. And you see here how out of the descending aorta, the MAPCAs are seen. So in other words, you see overriding of the aorta, you are not sure about pulmonary artery. You seek for MAPCAs, and you know you are at the diagnosis of pulmonary atresia with ventricular septal defect. The third disease is actually not so really diagnosed by overriding of the aorta because it's by far too obvious and is detected by the demonstration of the massively dilated lung arteries. And these are the so-called absent or severely dysplastic pulmonary valve syndrome. And this is highly associated with 22q11 deletion, 40%, 50% of the cases. And what you see here is in many cases in absence of the ductus arteriosus. And what you also see here is a blood coming from the right ventricle into the lung and coming back because there is no way to escape, or because the ductus is very small. So in general, we think that the dysplastic or absent valve is a secondary event, and the major event is hemodynamic. And you see here, this is such a case. You have dysplastic valve. This had ductus, but you have high velocities of 3 meters per second going in both directions. This fetus was detected at 12 weeks, and I followed the lady until 35 weeks, where the baby had an in utero death, unfortunately. The fourth disease is an overriding of the vessel, and you think first it is an aorta, but then looking more carefully, you'll detect, oh my God, no, this is no separate vessel. They are rising together from one group. And this is here the common arterial trunk, the truncus arteriosus communis. And you see there are different subgroups, but honestly, I will not focus on which subgroup is only when you are discussing with a cardiologist. Otherwise, I'm happy if you make the diagnosis. And even among cardiologists, there is no, let's say, same opinion. Look at, for example, the case you see here, type 4. It's actually the same, what we call today pulmonary atresia, and is not a truncus. So there may be also some discussion about nomenclature. And what you see here, you may see the VST, they are large. Sometimes you have the impression that the overriding vessel is even rising more from the right side of the heart. And then once you follow, you see that the pulmonary artery is rising from the common trunk. You see here the valve is dysplastic. You see a common origin of pulmonary artery and the aorta. And the main hint was an almost normal four-chamber view, sometime with a left deviation, plus a VST, and then the overriding of the vessel. Now, in our new edition of Dr. Abu Hamad and my book, we put in each chapter at the end what we called a approach to diagnosis. And what you see here is, if you see VST overriding aorta, check, is it the pulmonary origin artery there? Yes, it is from the right ventricle. And then we look at the size. If the size is normal, we'll call it simply overriding aorta or malaligned with VST. If it's small and moderate, with antegrade flow tetralogy, so we check if it's really antegrade or sometimes retrograde, because it can be also blue fallow. Or we check if very small and retrograde flow, it can be more easy with VST. Or the vessel is very large and it is an absent pulmonary valve syndrome. In this condition, we check for MAPCAS. If you don't see an origin, then consider straightforward pulmonary atresia. If what you see here is rising from the artery, then it is common arterial trunk. So in a way, we are helping, let's say, the examiner to find his way. Let's say our idea was that in soon future, and we have it here today, you have shown us very nicely how artificial intelligence will be helping us. So these can be put in an algorithm on the machine, and then the system will ask you, check this and check that. Now we come to the second group, which is the parallel cause of the great vessels. Here, automatically people will say, oh, it's a transposition, but be careful, because the most common condition you will encounter will be, the double outlet right ventricle. I'm sorry for the cutting here. Why? Because it's as common as transposition, but it has by far more common associated anomalies in utero from growth retardation, like trisomy 18. So there are other signs linked to its detection. And also the fourth-chamber view is very often abnormal, what is not the case in transposition. And you'll find let's say, general two subgroups. One, like an overriding, like tetralogy or fallow, where the overriding is more from the right side. And the other one is like a transposition, but you have such a large VST that it seems that the vessels are arising from the right side. And it has many sub-combinations. So we did these schemes for the book, where we showed that the position of the VST may be important, or is very important for the cardiologist, but believe me, it's really a big challenge. And this is something I'm expecting in future, that stick and 3D may be of big help in differentiating between these things, if it's subaortic, subpulmonary. But at the end of the day, the surgeons will anyway find their way and they will do the operation. Now, this is what we see here. We may see fourth-chamber view may appear abnormal, but in general, it may have a narrow left chamber. It has a larger VST, and the vessels are arising from the right side. So the trick is really to show, and I love to do it on color Doppler, how it is arising from the right side. You see here again, On the left image, you don't see clearly if it's a parallel course, but on the color, you see that the blood flow is coming from the right ventricle directly to the vessel. So let's have a look here quietly, and you see it's not so obvious always, but it looks abnormal grade vessels, and then it will be a big help to use here either a stick and to render with a stick or to use color Doppler. Look at how evident it is when you are using color Doppler, because you can see straight how blood is coming from the ventricles toward the two vessels. They are arising in parallel fashion. So this is why keep in mind, parallel course is rather double outlet, especially when you have VST or complex other malformations. Now we come to the complete or simple or DTGA. And I can skip this part of what it is because Valentina discussed with you this before. It has no chromosomal anomalies. It can be associated with cardiac anomalies like VST and pulmonary stenosis. And let's say that the problem in the transposition is that prenatally, the blood is anyway arterialized in the placenta, but postnatally, this oxygenated blood will come into the right ventricle, but will go back to the aorta and to the body. And as soon as the blood from the lung does not reach the body because the ductus arteriosus closes or the foramen ovale close and together, then the baby will get the blood disoxygenated and getting then into the body back, and the baby becomes blue. So it is one of the severe cyanotic blue disease, as we heard. Now, the trick is prenatal doesn't play a role. So in many talks in the past, we were showing you these nice images to say, you know, you can see the parallel course of the vessel and blah, blah, and so on. But this is not the way the diagnosis is done. And this is exactly what you were saying before, that this is only when you know that the diagnosis is there, but no one is scanning an oblique plane of the chest to demonstrate this parallel course. This is why, what are the tricks? The tricks is not this view, but the tricks is to find out and to demonstrate what I told you at the beginning, that once you are doing the 5-chamber view to demonstrate whether the aorta or truly the pulmonary artery is arising from the left ventricle with this bifurcation. You focus if the vessel arising from the left ventricle has a bifurcation. The aorta does not show a bifurcation with this large vessel. And then this is the typical picture of a left ventricular outflow tract with the bifurcation in right and left pulmonary artery. Often is the left side better seen than the right side. You see here the aorta going this way and showing the left pulmonary artery. And then come what you were showing, the different signs, the frog sign, double frog sign, boomerang, eye sign, bend sign. So you can call it what you want. The message is you see one vessel not enlarged in the upper thorax, showing slightly like a bend, because this is the aorta in the upper thorax. Ideally, you can even see it better in this view. I do not agree with that it is 96% of the cases. I think it's 90% of the cases, because 1 out of 10 cases you have kind of similar 3-vessel view. And this is where it is missed in early gestation, and it can be missed even in second trimester, unless you tilt the probe slightly. And I showed a similar case in last week in EASWOG World Congress on pitfalls on first semester scan. So what you do here is you are scanning quietly. You are happy, you use the color here, you see the 4-chamber view, you move and you want to demonstrate the V sign and you see only one vessel. And you ask yourself, oh my God, where is the vessel? The other vessel has disappeared. I need the V sign. And it's unlikely to be, because it's not dilated, to be like this pulmonary atresia and so on. If you go back on a SIN loop or on stick, for example, this would be ideal, or on fine technique and so on, you may detect that the vessel arising from the left ventricle, as you showed before, is bifurcating, and this is typical pulmonary artery, and the other one is over it. Then knowing that both are over each other, then you can tilt the probe again, similar to the technique we did before, and you get the parallel course of the vessels demonstrated. Okay, so I hope you got it. And here again, the 4-chamber view is uneventful. The 5-chamber view you may miss if you don't see the bifurcation. So focus not only on the overriding, but also on the bifurcation. And then you go to the 3-vessel view, you are surprised, you turn the probe and you get the diagnosis. So this is my daily work. When I have a suspicion, this is what I do. 4-chamber view, 3-vessel view, I see, oh, one vessel, tilt the probe and get the parallel course. You see here also on stick how it can be shown. And ideally, and you showed nice images of Giuseppe Rizzo, but you see here, this is also what is also possible to demonstrate in a spatial view from ideally from the left side, the parallel course of the vessels in 4 different fetuses here, with the transposition, and you see that the lower vessel here showing the bifurcation arising from the left ventricle while the aorta is rising from the right ventricle. Now, a more complicated disease is the so-called congenital corrected transposition, because I hope the group is listening for 2 afternoons that they need to get even higher. So why is congenital corrected? Here is the, let's say, in not comparison, but conversely to the other disease. What you see here, we have double inversion. Double inversion means we have the anatomical right ventricle connected to the anatomical left ventricle, and the anatomical left atrium connected with the anatomical right ventricle. That means we have a transposition at the level of the ventricles, and again, a transposition of the great artery. So it is double inversion. What means that for the blood coming from the body in blue will reach the anatomical left ventricle. Believe me, the blood does not care. The blood wants to know where it at the end would reach. It reaches at the end the lung, and it's arterialized in the lung. The blood coming from the lung will reach back to the body. So from the hemodynamic point of view, it is corrected. This is why it's called corrected, but it is a double switch. Double switched, yeah. In other words, if you have a normal four-channel view on a normal conditions or a transposition, in a corrected transposition, you have here switched ventricles. And this is the way you make the diagnosis if you are a careful examiner. Because under normal conditions, we told you that the apex of the heart is formed by the left ventricle, but here, the left ventricle is on the right side, and this can be a big hint. Look at now this image. When you look at the video in general, believe me, the first time you see it, you think it's a hypoplastic left heart syndrome, because you see on the left side, a small ventricle not reaching the apex, and so on and so on. But if you look, if you put colored up, you see the blood coming in, which does not fit into the hypoplastic left heart syndrome. And then, because you are excellent, you are a careful examiner, you notice, look at the valve, that the valve on the left side is lower attaching than the valve on the right side. Why? Because the valve on the left side is the anatomical right ventricle. And then, because I told you it is a correct transposition, the vessel arising from the heart are always arising from the left ventricle. That means from this ventricle here will be pulmonary artery arising. And this is here, I will skip this one, too complicated. And this is what we see here. We look at the 5-chamber view, but you don't see a vessel going to the right. This is later the moment we say, stop, there is a problem here. The vessel is going out to the left, and this is the pulmonary artery bifurcating. And in the next plane, out of this ventricle on the left, which is the right ventricle, then the aorta is arising. Yeah, I can understand it can be complicated, but we have here, there is no single plane you can get in, which is normal in this heart anomaly, only the abdomen, and not even all cases. And you have an abnormal 4-chamber view, you have an abnormal 5-chamber view, you have an abnormal 3-vessel view. But at the end, it reminds you also this bend sign of the aorta with the transposed vessel. But I think this is something you may see. So I've seen even 2 cases in early gestation as well. So in other words, they have very often large VST, they have very often pulmonary stenosis, you have a VST, pulmonary artery arising, and in animal position, the bent aorta. So I come now to the end. I want to summarize what I said at the beginning. This is not a pipe, because this, an aortic override, is not a tetralogy, and the parallel great vessels are not transposition of great vessel. It is a first hint. And once you look at more detail to color Doppler by using stick, by using different tools, I will show this afternoon, it can be tetralogy, but it can also be malalignment, VST, pulmonary absent pulmonary valve syndrome. It can be a common trunk, but it can also be for the parallel vessels, not only TGA, but the most common double outlet, or complex heart anomalies, or corrected transposition of the great artery. I hope for your daily work that you can use these tools, and I hope one day that FINE and other tools will be of big help in getting to the at least close diagnosis to what we want to see. And I thank you very much for your attention. I will stop sharing here, and we'll be now ready for questions. Thank you.
Thank you very much, Rabbi. I substitute Professor Rizzo because he's unable to connect. He's in Egypt. Probably there are problems with the connection, so I will help Valentina for the discussion. First, I invite the participants to write in the Q&A section if they have specific question, but I also solicitate our panelists speak between each other or to point it out something or make comments if they want, because I think it was a very interesting and broad, session with a lot of information, really. And I think very helpful in showing how complicated it is really to look at the fetal heart and how many details we have to know. But I think on the other end, we have also the facilities given by these, intelligent navigation system that can help a lot, at least to detect which is the suspect, to arrive sometime to the full diagnosis, and also eventually to be sure that we may have, as it was shown before in some of the slides that I've seen from all the authors, you see that going around the world, the detection rate of fetal heart anomalies is much variable, depending from the center, depending from the attitude and the enthusiasm sometimes of the ultrasound specialist. So I would like to first to ask the panelists what they think about this discrepancy. It's also due to the fact that in some center, for instance, instead of a specialist in obstetric gynecology, is a radiologist to do this, or even a technician, and therefore this can hamper the visualization of the even most common anomalies of heart. What do you think about? Please open discussion at least, and then see if there is some question from the floor. Jan, Alexander.
The two vice are still muted, so I will say some words. In my experience, when I'm traveling through the world, I know since the beginning the data of Laurent Fermot and France, and especially Paris. And let's say, to my understanding, it was always the screening policy of the country. In Berlin, we have outstanding data, outstanding. So you may have one case missed a year, but in general, I think the 30 transpositions are almost all detected, or 20, but because we have almost all patients are sent to a specialist who's doing the whole day on the ultrasound.
What do you mean for the country policy? Because this,
so
the country should have at least a specific exam for those who practice prenatal ultrasound. For instance, in France, this is typical. You cannot do prenatal ultrasound, but you should have some, proficiency given by the French College of Obstetric Gynecology.
Exactly.
So I think it is something that you need to have.
In Germany, you don't need. In Germany, you don't need.
In Germany, you don't need it because you have a very good, because residents are already trained in ultrasound.
No. We don't have good data in Germany. We have in some big cities good data, because the women know that this guy and that guy is working mainly and only and the local doctors at the end,
that is not a country policy, Rabbi. What you are saying is a little bit different. I mean, you think that you should have a country policy or super expert in the country? Which one of the two?
Look, let's say in the UK, you have, for example, sonographers, and they have a checklist to do. And in the US, they have also checklists. If there is no indication, you don't need to look at the great vessel, but they encourage to do this. So, there are different places. And in the Netherlands, there was for a year no screening. You had detection rate of 3%.
Yes.
And I will hear what Jan will be saying on his experience. He's in the center in Lübeck where it was pushed by Uli Gembroch when he went there.
Yes. Yeah, I mainly agree with Rabbi. I'm of the very same opinion, and so I'm from our perspective, it is very depending on the physician who does the ultrasound, and indeed it is in the larger cities, not in the rural regions. In the larger cities, you get your experienced ultrasound, and the detection rate should be high. And I see this detection rate, whether this policy in Lübeck and in the wider part in Hamburg as well, in the northern part of Germany, and this the same applies to Berlin as well. And so I agree with Rabbi
Good. And your experience, Alexander?
I'm also having the same opinion. I think it absolutely depends on the screening policy that is introduced in the certain areas. We know from the German data that are truly limited. There was a publication, I think, in 2005 from Germany with a PAN study. They came up with the overall detection rate of cardiac defects of approximately 12%, as far as I remember. And that is extremely low. But we know that in specialized centers, the detection rate for defects is as high as 90%. So I think if you want to reduce the undetected the rate of undetected cardiac defects, you have to implement a screening policy. And in Germany, to be honest, there is no general screening available in expert settings, because it's usually done by indication through the normal gynecologists. Yeah.
Okay. Listen, I have a question for Rabbi Chaoui. First of all, this Turkish colleague is thanking you for all of you for the great presentation, but as a specific question, how do you differentiate the truncus arteriosus from big aortopulmonary window? Any tips and tricks? Rabbi, do you want to answer?
Well, difficult, you know. For me, simply, there are two things. Simply, it is, let's say, the frequency. I'm seeing some, I don't know, 30, 40 common trunk. I've seen only 1 or 2 windows. And in the windows in general, to my knowledge, you have 2 separate valves, and then later on they connect. While in the common trunk, you have a common valves in the beginning. And this is the major, for me, the major difference I could give her. Another one is the let's say an isolated window is quite rare, and most cases may be associated, let's say, tetralogy and all these things. So this is why I don't think this could be of help. So first of all, forget a little bit about the common the window.
Okay. And another question that is open.
Listen more about the window. I remember we had a nice session with Kypros group on one of these Sundays. On the website of Nicolaides, there is one talk on focusing on several cases of window. You can go there and listen to them. In the UK, they had a good collection. Yeah.
Okay, very good information. Listen, I think that this is open almost to everybody. After you diagnose a congenital heart defect, what is the most correct ultrasound follow-up? 1 week, 3 weeks, 4 weeks? What do you think that is in agreement? Maybe each of you may say the opinion you have in your, for instance, protocols or so on. Rabbi, you want to start, and then the other?
I will.
Congenital heart disease.
If you don't mind, can I share a screen for a second?
Yes, please.
Because this is nice on interaction here. Look at this one here. For this Turkish person who's spending the evening.
You want to finish the
No, I want to show you the
previous one, and then you go with the second question, okay?
Yeah, but you know, this is the aortopulmonary window. You have 2 vessels, but you have a connection side by side, and you see here, you have separate valve, but you see that they are opening of each other on the side here. And color Doppler, you see, it is really tricky because there are 2. It's like a V, but you see, it reminds you at the first moment the double aortic arc. It's not they're going together. So I hope the colleague can learn from this case. You know, see here, this was my only true isolated case I've seen here, and it's very well documented, but it was an old case. Yeah, the other one I will keep. I don't want to speak alone, so let's go for the 2 big guys who were working for years at big centers.
No, the question was, what is your protocol to follow up when you diagnose a congenital heart defect? You follow up 2 weeks, 1 week, 4 weeks. What do you do?
Yeah, it strongly depends on the underlying abnormality. So we all know that aortic stenosis might develop into hyperplastic left heart. So we have to follow up this case, and this might be as early as in the first trimester or the early second trimester. So I would judge my follow-up policy depending on the underlying condition. Yeah, it's when I'm convinced and confident with my diagnosis during second trimester ultrasound scan, I will reschedule the patient in 4 weeks, for example.
Okay. Alexander?
I'll turn on the microphone again. I would also make it dependent on the underlying condition. For instance, if you have just a transposition of the great arteries with the normally growing fetus, normal Doppler values, you can push it probably to 4 weeks, and you can do it together with the hospital where the delivery is planned. So we try to find a management with the hospital. And if you have a fetus that is at risk for intrauterine demise, we adjust the time frame to this condition then.
Good. Valentina?
Yeah, I agree that everything depends on congenital heart disease, which is presented, but usually if you expect it to see after some time some restriction of foramen ovale, or you see that will happen, you will invite according to the rules of in our centers. We can do, for instance, a balloon septostomy until 34 weeks. We will invite in appropriate time to perform it. If not, we'll of course follow according to the findings.
Yeah, so from my point of view also, Dr. Ligorio, look, the issue is, I think it's a little bit more complex. There is no answer for all. I can tell you, VST take muscular VST 10 weeks. So the issue is, what are we expecting from a control? I think, I don't know you very well, I don't know at all, but if it's your first diagnosis of this anomaly and you are not really very safe, go for a week, read at home, be prepared, and next time you know exactly what you are looking at. You can take my book, of course, you can read and you can scan quietly, and then you have the complete package. If you ask experts, they scan, 1 minute they say, okay, it looks like a transposition, or let's say take another one, double outlet right ventricle, then you have to offer invasive procedure. So you may have a check a few days later, because she will go home, she will ask, she will check on internet, and then you have time after 1 week to discuss again, and then she can decide to have an invasive. Now, provided we know all the things, is we know the diagnosis, what are we expecting from a control? Is there any intervention going to be done at 26, 27? No, unless the aortic stenosis is going to be dilated by balloon or no. All others, or if you have an Epstein leading to hydrops, these one may be needing. But if you notice at 26 weeks, the fetus has hydrops, or 25 weeks or 27 weeks, it's anyway dead. So this is why you should make it in the context. Different is 32 weeks, and you have some cardiomyopathy, and these, and then we'll check them weekly until we decide the delivery. So it depends on the anomaly, and think always what I'm going to do in the control to tell her, yes, it's a VST, yes, a VST, yes. So it's not the visit of the baby. And at the end, honestly, I would recommend you not to do it very often, because you will always be missing something. And the lady will say, you know, I was 10 times at the control, no one saw that the lung veins were not there. So this is, you see it once, you say, oh, I miss it. Twice, but then you should be sure that every time you. So let's say a long answer, but this is a very frequent asked question in meetings. So how often is the control?
I have a last question for Gustavo. Gustavo, there is a question for the fine. Do you think that the fine is useful in the first trimester for the assessment of fetal heart, or there are limits?
There are limitations, and there are some authors, including Dr. Young, that made, and Dr. Alex also as well. They did some cases Dr. Jan presented one. I think that also in the UK, at Imperial College, they were trying to do it with relative success. The reason for this is that, number one, the geometric model for the first trimester is not the same on second trimester onwards. So, for example, the location of the aorta is different at that age. So we were considering to readjust the geometric model in order to go below 17 weeks. As I believe it's a decent threshold, 17 weeks to term. But then the other thing on that is that it is kind of difficult to get a good stick when the fetus are this young, because they move a lot. So we believe that if a doctor wants to use it, there is a tool in FIND that is called the VISA, the Virtual Intelligence Sonographer Assistant, that may find those planes that are necessary to adjust the views. But it's a little bit of experimental. I don't see this like a clinical.
Thank you, Gustavo. We are going closing. There is a quick question for those of you who would want to answer. Which plane would be better to assess the fistulas in pulmonary atresia? Do you have a quick answer?
Which what?
Which plane would be better to assess the fistulas in pulmonary atresia? And
the MAPCAS.
No. It's I think these are the ventriculocoronary fistula.
Yeah.
Dr. Virginia Machado, so she's a specialist from Brazil,
Yes.
I know from earlier.
Yeah.
Virginia, I think that's what I will be doing. I'll be doing is probably the 4-chamber view, and then we augment the peak velocities, and you see where there are the turbulences. The trick to diagnose this condition, in my experience, is when you see a very small ventricle, and you know that there's a pulmonary atresia, but still blood is entering and not a regurg, because there is no blood entering into the closed ventricle, not returning back. If it goes somewhere, it has to go somewhere. So you move up and down. And the problem is that we don't know if we see on the border the pericardial fluid or true vessels. And this is why I will focus on looking to the myocardium where there is some blood. So more between 4 and 5 chamber view. This is the plane I'm using.
Very nice. I think that with these very super specialistic details given by Ravi, we can close this course that has been, as you see, divided in 2 parts. The first part was very basic with the function and so on. And now we go a little bit deeper in different aspect of congenital heart disease. I would like to thank every speaker and also the chair to run a very nice, interesting course. Will be available to all those who were not able to connect today. They will receive a link to look at all the course, the first and second part, but I invite all of you to be next Monday to the closure of this part, which is dealing with the simulation, ultrasound simulation based training. And you may register as well, and you may see then the course again by video recording. So thank you so much for participating from all over the world, and thank you to the speakers. I think it was very interesting for everybody, and also to have taken some of your busy times for participating to this. We'll keep in touch, and we'll see how things are going, and hopefully ameliorating our capabilities to detect congenital heart anomalies, which are the very difficult part in our prenatal diagnostic tools. Thank you so much to everybody. Have a nice rest of the day.
Thank you. Thank you all.
Thank you.
Thank you all. Greetings from Lübeck.
Thank you.
Thank you.
Thank you very much. Bye-bye to everybody.
Bye.
Bye.
Ciao. Thank you.